So warm greetings to all present. On behalf of NQSN, I, Dr. Sonam, welcomes you all for today's author speak session by Mr. Praveen Kumar. So without a further ado, I would request Ms. Gina Pradeep to welcome the participants and our guest speaker for today. Ms. Gina Pradeep is advisor at NQSN India and senior nursing officer at Kalavati Children's Hospital. She has got 25 years of clinical experience and 12 years of teaching experience. She is a PhD scholar and a life member at TNAI and IANN and a Florence Nightingale awardee. So I request you, ma'am, to introduce our guest speaker. Over to you, ma'am.
So thank you so much for that nice introduction. So it's my privilege to introduce our speaker for today, Sir Dr. Praveen Kumar. He is an Associate Program Director at FHI 360, formerly known as Family Health International. He is a public health professional with 2 decades of experience in India and South Asian countries. Sir has worked with UN agencies and international organizations such as World Health Organization, UNICEF, USAID, USAID, etc. Sir has been trained in Six Sigma Black Belt from the American Society of Quality. Sir is also a member of the Canadian Public Health Association and the Indian Public Health Association. Sir has many international publications and chapters in book on quality improvement in MNCH and nutrition. So welcome Dr. Praveen Kumar, and over to you, sir, for the session.
So you're on mute. Yeah.
Can you hear me now?
Yes, we can.
Yes, sir.
So thank you, Gina, for wonderful introduction, and good evening, everyone. And I want to thank you, NQSN team, for providing me opportunity to share some of our work, especially this antenatal care services work, in fact, done by Kanpur Medical College team. I'm sharing on behalf of them. So thank you very much. Just let me share my screen. Is it visible?
Yes, it is visible, sir.
Okay, so thank you again, and let me introduce my organization also. And I have been already introduced by Jena. So I work with Alive and Thrive Initiative, and Alive and Thrive Initiative is managed by Family Health International. Family Health International is a US-based organization working in 60 countries globally. And in India, Alive and Thrive Initiative is working past 2015. And here in India, what we do, we are a technical agency to provide technical support on health and nutrition programs to Ministry of Health and Family Welfare, Ministry of Women and Child Development, and Niti Aayog as the central level. We also work in 4 states, Uttar Pradesh, Bihar, Gujarat, and Jharkhand primarily, and very, very closely working with the state NHM, ICDS department. As a technical agency, our role is there also to work some, implementation research, develop some good practices models, and sharing these models with the partners and the development partners. So we are also working in the community level in a couple of districts in Uttar Pradesh and Bihar, where we closely work with district NHM, National Health Mission, as well as ICDS officials. At the community level, we also provide support, especially in developing some, innovations and models to the FLWs and ASA, Anganwadi worker, and ANMs. We also have a partnership with donor agencies like Bill and Melinda Gates Foundation. They are the donors. Technical support agencies in the state. We have collaborations with UNICEF and WHO. We have collaborations with professional associations as well as medical colleges. So as part of our quality improvement initiative, we are working at the facility level as well as the community level. So we are working around 25 medical colleges in Uttar Pradesh, Bihar, and Jharkhand, and for quality improvement initiative, which includes MySIN service delivery protocol, ENT also facilitated and coordinated to develop an undergraduate curriculum for on mycin, which has been now adapted by Uttar Pradesh and Bihar. Of course, we are working with the quality improvement on health and nutrition with these institutions. Along with this, we are also working with private hospitals to provide technical support on quality improvement, as well as we are working for district hospital and CSC, PSCs in Uttar Pradesh, Bihar. So far, Alive and Thrive has trained around 3,000 health service providers in medical colleges and district hospitals in past 3 years. Alive and Thrive is also working for ICDS departments for supportive supervision app. So ICDS UP has scaled up this quality improvement, adapted the quality QI approach and scaled up in across all the 75 districts in UP, which is being this model is being used by more than 4,000 ICDS supervisors, those who will be supervising 180,000 frontline workers. So we are also piloting some quality improvement approach in Uttar Pradesh and Bihar. So this is one of our area working on the quality improvement in 4 states in India. So I'm closing my video because of to improve the internet connectivity. I hope it is okay with you. So why we work for the anemia and improving the antenatal care services in India, space and in few medical colleges. So Kanpur Medical College is one of the medical college, and if we see this NHFS figure from the Uttar Pradesh, where we know like pregnancy is a nutritional at risk time, and the nutritional status of a woman before pregnancy and during pregnancy can have a substantial influence on fetal and maternal outcome. So we can see here like around half of the pregnant women are anemic in Uttar Pradesh. And if we see the antenatal care coverage in NHFS 5, it's only 60 to 5%. And for antenatal care services coverage is only 42%. Even less than half of the pregnant women are receiving more than 4 antenatal care services. IFA consumption, of course, is a major, cause. Major which provide impact on improving the anemia is just only 22.3% in Uttar Pradesh. EIVF has, even if you see the NHFS 5 and NHFS 4, it has been reduced. It was already low 25%, and it has come down to around 24% EIVF. Early initiation of breastfeeding. So for all these improving the barriers, nutrition outcome, health and nutrition education is important, and which is core program of health and ICDS department. So that is again, only half of the pregnant women receive the health and nutrition education. My slide is not moving. I have to do something.
Escape and come back.
Sorry for that.
Do you want us to present on your behalf?
Yeah, would be great. Please do it.
Sure, sir, I'll just project.
Yeah. Okay. So can you go for the next slide, please? Thank you. So yeah, so here I wanted to share the experience or our quality improvement approach adapted by Ganesh Shankar Vidya Memorial Medical College, which is known as GSBM Medical College, Kanpur. Kanpur Medical College, one of the 25 medical colleges where ANT was providing the support. And of course, we have trained this medical college staff also, and including OBGY, pediatrics, and community medicine. So this hospital was very much keen, and they have especially requested us to come and help them in the starting phase of our training 2019. This hospital is a big high caseload hospital, and it have more than 1,000 beds in this hospital, which includes 120 beds dedicated for the pediatric department, 235 beds for OBGY department. It has a team of faculty and senior doctors, 48 residents and 34 staff nurses in OBGY department, 8 faculty and senior doctors, say 37 resident and 31 staff nurses in pediatric department. So this is the human resource and infrastructure. If we talk about the average service per month is here, women, those who come for the OPD in this hospital are 2,700. Antenatal care services load for this hospital is 325 per month. Deliveries occurs here 270 on an average. And if you see the pediatric OPD is average around 5,700. So this is one of the high caseload medical hospital in Uttar Pradesh. Can you go for the next slide, please? Right. So as I earlier mentioned, like Alive and Thrive has trained three departments on point of care quality improvement approach, and the senior doctors and administrators requested us to help them to improving the antenatal care services, as they have learned from the point of care quality improvement approach, problem identification at the first part of the first step of this approach. We all know that like these we had the point of care quality improvement approach has a four core steps: identifying a problem, form a team and writing an statement, analyzing and measuring quality of care, developing and testing of change, and sustaining improvement. So the same, I mean, this point of care quality improvement approach has been adopted by the medical college, as well as we have provided the technical training on mycin in the same facility. Next slide, please. Okay, so here is the aim what they have chosen to work on. As I mentioned here earlier, like antenatal, they wanted to improve the antenatal care services, and this is very complex problem, especially in all the medical colleges in Uttar Pradesh. And if we talk about the high case load facility, yes, managing antenatal care services is always difficult, because of course the staff is limited over there, those who work for antenatal care services as well as the other services also. So as a first step, they have identified the problem, they have a form a team, and developed a smart aim. The aim what they have developed formed, like increase hemoglobin measurement among pregnant women from 58% to 70% over 5 months. So hemoglobin measurement was the only data available in this institution, so that we could take 58% as a baseline. The other part of the antenatal care services, the team wanted to increase measurement, height and weight, and nutrition counseling among the pregnant women from 0 to 70% over 5 months. So they have chosen 5 months time because the caseload was very high. There was no data available for height and weight measurement and nutrition counseling. So we can't say there was no services was provided, but if you see the next charts, we can see there was, of course, the lack of the services of height, weight measurement, and of course the nutrition counseling. The tool they have used the process mapping, because antenatal care services is where we provide the care in various steps. So the team had decided to use the process mapping, and they have identified the bottlenecks in each steps and try to apply the various changes. And as this is the complex project and multiple steps of care as engaged, so multiple change ideas has been developed by quality improvement team. The key idea was there implementing systematic patient flow management system, because there was all chaos during the services. Sometimes pregnant women comes directly. The first the new pregnant women, those who are registering for the first time, comes to the registration counter. They get registered and they directly go sometimes for height and weight measurement. There is a section for height and weight measurement. Sometimes they go directly for consultation for the doctors. Sometimes they go for the counseling session, then they go for a HBBP. So their priority was there to meet the doctor, not getting these, additional services for the antenatal care services, so that doctor can take, do the checkup and she can get a consultation. So team has decided to come up with a systematic patient flow, and this is the one of the change idea they have applied. The other was ensuring delivery of all essential maternal nutrition services during antenatal care, so that there should not be any miss for antenatal care services. So they have established separate counters for each services, and the second last counter was there for the consultation with the doctor, starting from the registration, and last was the counseling of maternal nutrition component. The other important, as I mentioned, the maternal nutrition counseling, how to improve the maternal nutrition counseling. Counseling is always challenging, because measurement is again a difficult in the counseling, and quality of, especially in quality of counseling, and due to lack of stock, they were facing challenge how they can improve the counseling. Data recording was another challenge. So they have come up with a register specifically developed for antenatal care services. They will capture the antenatal care services with the register. This was another change idea, PDSA they have done. Next slide, please. So yeah, here you can see the improvement of hemoglobin and maternal nutrition counseling. The training, INT has trained point of care quality improvement approach in April 2019. Early May, they have collected some baseline data and started the PDSAs. And late May, they are getting some good improvements. So starting from HB checking 58% in April baseline, and May it was on 60%. It has increased to till 91% February 2020, and you are seeing a dip in March. It was due to the COVID surge has started in March 2020, and we have collected the post-COVID data also, and it's sustained. Next slide, please. Same story is there with additional component of antenatal care service like height, weight measurement, and blood pressure measurement. They improved well, and they were slightly down in March, and they were down again more. We have collected data during this COVID-19, because the hospital has been converted into COVID management hospital, and there was no antenatal care services were provided. But after COVID, they have started the same. Next slide, please. So this is the exit interview done by quality improvement team and the community medicine department team, where they wanted to assess the knowledge level and the retention of the messages after the counseling. So the exit interview has been conducted by the community medicine department on importance of weight gain, importance of calcium, importance of IFA, frequency of meal, and diet diversity. So these were the key messages has been selected for exit interview. However, there are other messages also for maternal nutrition counseling. So you can see, like, they have started assessing in August 2019 until March 2020. Around 80 to 85% pregnant women has a retention of the maternal nutrition messages. Next slide, please. Okay. So now we come to the challenges. The very common challenge what we face working with the QI approaches is, the staff is reluctant to learn and apply the quality improvement approach, as they see this is the additional work for them, and they have to work as additionally for quality improvement approach has to spend extra hours for doing this, and this was their initial thought. So yeah, after training, we try to convince them, no, this is not, this is a magical approach. This even, in fact, will reduce our workload also. And this was the high workload facility. So yeah, so they were a bit reluctant on learning on QI approach. So of course, they have shown like they are lot of work other than the antenatal care services. So why quality improvement, especially the routine service provider were there, like staff nurse and doctors were electing, but we have engaged some other student also, UG student, SR also were engaged in various programs, and they were convinced after some initial period. Data is key. So in quality improvement, as we know, so there were partial data was available, no record available for additional antenatal care services other than hemoglobin. So lack of data was another challenge. Limited capacity of lab test report. So yeah, they were prioritizing the urgent and emergency tested. Antenatal care HB testing was not priority from the hospital staff. So the team has engaged lab technician as part of quality improvement team. So the people those were coming from the outside were unable to collect the report at the same day if they are going for the test, the pregnant women going for the test, and they were unable to share this report with the doctor. So usually they don't come back to collect the report and share with the doctors, and they don't get to know whether what is their anemia level. So this was the one of the big challenge working with the hospital. So we engaged this lab technician, and he himself has suggested, okay, I will prioritize especially those who are coming remote areas, has their home in distance from the Kanpur Medical College. I will prioritize their test and will try to provide in first half, so that they can share their reports in second half. So those who will be submitting their HB checking in first half, I would be able to provide the report in second half. So for outside people, the remote area people, it has been decided, okay, they will come and they will and this lab will try to provide the report the same day, so that they can share with the consultant. Measurement of outcome for both and mother and newborn, because this is tertiary level care hospital in Kanpur, very famous hospital. Even remote areas, pregnant women comes here for antenatal care services and other services, but not necessarily they come for the delivery. So those who are getting for antenatal care services, not necessarily they are being delivered in the same facility. So the challenge was there to measure the outcome of pregnancy in terms of the condition of mother and the newborn. Next slide, please. So learnings from the medical college was there, because the HOD of the department was very proactive. She engaged since starting. She was engaged since starting, and she has provided all the support, administrative support and the technical support to the staff, as well as the team. QI team has identified some active members. They have engaged some active members. QI team also engaged Red Cross peoples as a volunteers to manage the queue and systematic flow of antenatal care services. Leadership also engaged SR and JRs for counseling services and all, and they could manage. The other learnings were interdepartmental coordination committee. So interdepartmental coordination committee has been formed in the hospital, where HOD of OBGY, pediatrics and community medicine was part of the committee, and principal of the institution was the chair of the interdepartmental coordination committee, where they got help from various help from the other departments also, like counseling assessment has been done by public health, community medicine department. All the data collection and data analysis has been done by the public community medicine department. Of course, some case study development. Department also coordinated with public health system. So, for example, they have faced the challenge like they need an MCP card for the record so that the beneficiary could have a record with them, because the hospital has developed a register where they can see a record, but what should have beneficiary have? So hospital, there were lack of funding, so they cannot print the MCP card. They have coordinated with the chief medical officer in health department, and they agreed to provide the MCP card. And they got all the MCP card from the health department, and this was one of the example of interdepartment committee as well as the public health system coordination. No additional resource has been used during this project. Either the staff has been reassigned the work or reorganized the task. For instance, like I was quoting the example, engaging the SR on ensuring that all antenatal care services are being provided to the pregnant women before leaving to the hospital. JR has been engaged for counseling in addition to HIV counselor has been engaged. Red Cross volunteers has been engaged to manage the queue and manage the patient flow. So these were the examples of reassign and reorganizing the task. Counseling was always a challenge, and we also see as the public health facilities also district hospitals, CSC, PSC, where we are facing difficulties for the counseling was here. Yes, of course, this hospital was able to manage the counseling also with the help of GR and an HIV counselor. No additional new staff. Sustainability is I mean, yes, this is a learning, in fact, not a challenge for the sustainability, because the leadership was engaged since starting, and the change has been made in the processes. So the change sustained even after the COVID. This hospital has been converted into a COVID care, and they have started again doing the same process what they have developed prior to the COVID to provide antenatal care services. Next slide, please. So so if we talk about Deming's principles, and I correlate it with our learnings, again is the same. Quality improvement is the science of process management. Of course, yes, this quality improvement team in this hospital has applied and worked only the process management. So measurement, yes, of course, was a challenge initially, but the team has come up with the great ideas to develop a measurement system, starting from assigning a person to record all the antenatal care services, keeping a separate register for antenatal care services, getting a mother and child protection card, MCP card from the health department. So these were the initiatives they have taken. So again, the managing care means managing process of care, not managing physician and nurses. So HOD of all three departments was very much clear. They will be focusing on the processes. They will not be, managing or monitoring to the providers, and it worked. And the right data in the right format, in the right time, in the right hand. Yes, of course, the data has been very much used, not only to track the process progress, as well as to track the last outcome and sustainability also. Smart engaging a smart cogs. Yes, even the quality improvement team has engaged initially while they were forming a team. Those who are smart and interested and wanted to work on the quality improvement team, they have engaged them. It worked well. Next slide. So how about scalability? Okay, the session is meant for only for this, I guess, sharing the case study of published in BMJ, but I wanted to take opportunity to share the learnings from this medical college and the other medical college are not limited to do the practices in their own medical college hospitals. So Alive and Thrive has coordinated with both the state in UP and Bihar, and of course we were we have been asked by both the state to work on the quality improvement in the medical colleges. So Director General Medical Education has issued a letter in 2020 to scale up this approach in across all the medical colleges. The mission director and the secretary of Bihar has issued the letter to scale this approach in all the district hospital and CSC, PSC. So Alive and Thrive has trained all the medical colleges in UP and Bihar on MyChin and QI approach. And in few medical, and these medical colleges will further help to the district hospital and CSC, PSC to use the quality improvement approach. And these district hospital people will be helping to the CSC and below CSC level. So the work has already been started. Government already is in buy-in, and the learning what is here I shared with the Kanpur Medical College, and we have learnings from some other medical colleges are being scaled up across UP and Bihar. Thank you. So Jena, I'm open for the questions. Over to you.
Yeah, thank you so much, Dr. Praveen Kumar, for that wonderful session. And it is great to know. Am I audible now?
Yes, yes.
Okay. It's great to know that your quality improvement project has become a model for other facilities, and other state governments are trying to adopt the same. So we have a lot of questions here. So I can see there are total 13-14 questions, and one from all the 10 questions are from one person, Sri Rupa Sri. Mantian Rupa Sri, please unmute yourself and speak or ask questions. So it is all the questions are to you, sir, regarding
Hello,
the project. Yeah.
am I audible?
Yes, yes.
Yeah, I have put my questions on the chat box.
Okay.
First of all, it is a very great presentation. I should thank the speaker for this wonderful presentation and QIP at such a massive level. My questions are pertain to QIP. I just wanted to know whether this particular program, in terms of performing, as you mentioned, as a PDCA, Plan Do Check Act, was it performed at the pre-training level? Was the level of all the implementation was being performed, and was it being piloted? And how far was the sample size? What is the methodology? And second thing is, you mentioned about the training program. Was the training being standardized? And second thing is, post-training levels, has these training been compared with the pre-training and the post-training? Train the trainer program, was it being conducted? What module was used? What is your model of training? What is your documentation being used, or level of SOPs? How many levels of SOPs has been done? Financial aspect, you said about scalability. In terms of scalability, when you are implementing, so to what points it is being done? And I also want to know what are the pitfalls of this particular training in PDCA, that is Chuck level. What pitfalls has been done? What challenges, what limitations was being done? What is your software being used for analysis and implementation point? And was this taken in the perspective of patient confidentiality and privacy, because you're taking patient data? So ethical
Yes, sorry, I will forget. I mean, it will take hours to answer
So,
you. Otherwise.
I can ask you, sir. Sir.
Yeah, I have put all those in the chat.
Yeah,
box.
I will read it out for Dr. Praveen Kumar, sir.
So first,
So the first question was, shall I
PDS.
read out the question? First question.
Yeah, please.
What were the bottlenecks observed while implementation?
See, bottleneck was, of course, the first bottleneck. What I said, like they were even not agreed to take the training of quality improvement, because they were thinking like, yes, we are come with additional training and methodology to work there. So this was the first challenge, and the leadership of the medical college played a great role to convince them to take the training. Once they have taken the training, and we have shared some example, they agreed to work on the quality improvement. So
Okay.
yeah, what is the second question?
Second question is, please mention the steps of process mapping and its applications at the patient perspective.
So I'll share the case study. The process mapping is very much mentioned there, because post process mapping and the pre process mapping and post process mapping, as we know, like antenatal care services includes various steps of care, starting from the registration, ending to the counseling and assessment of the counseling. So yeah, we will share the case study with you, the publication. You can see the process of the care, the steps involved, and the tool process has been involved, how they used it.
Okay.
So can you just switch on your video now?
Sure.
Thank you. Ma'am, you can continue.
Okay. The third question is, what training methodology was used and how long was the training incorporated? What was the duration of the training? Yeah.
Yeah, it's a good question. Point of care, we use point of care quality improvement methodology for QI, and this is 2-day training. in fact, but we have reduced this training for 5 hours training. So we have customized this training module for 5 hours, and we have used the 5 hours presentations and videos to train them.
Okay. The next question is, have you developed any training module for this training?
Yeah, of course. I earlier mentioned we have customized this point of care quality improvement training, and we have adopted this. We have a training module. If you are interested to see the training module, I can share the training module also.
Okay. So the next question is, has it been piloted for the training methods and to determine the standardization of the content? Or
so point of care quality. Yeah, so POKI module is well tested in 2017-18, and of course this customized model was also tested in various hospitals in Uttar Pradesh as Bihar. This 5-hour trainings, what I am talking about. Of course, it has been tested. Many of the case studies are there, has been developed. They are not published in international journals, but the case studies from these medical colleges, 25 medical colleges, out of 25, maybe around 15 medical colleges have a case studies. They have generated the case studies.
Okay, I think madam is asking for the training module. That module has been piloted before use.
Of course, yes, it has been piloted.
Okay. So there is a question from Dr. Kedar. I hope Dr. Rupasri does not have any more questions. Okay. Here we have Dr. Kedar. A question from Dr. Kedar. How is the improvement sustained, sir? And can you plot it on SPC charts for better understanding?
See, I shared my the findings from the medical college. If you see the result here, they are till March 2020. When the COVID has started, the hospital has been converted into the COVID hospital. And after again, they back to the normal services. The antenatal care services has started. So we have the data post-COVID also, even for 2021 and 22 till March 22. I have the data from the hospital. It is sustained data. We can share with you. And the sustainability region is again inbuilt in the quality improvement approach, point of care quality improvement approach. If the project is being doing on the as per the training, the protocol has been mentioned in the training, the project will be sustained. Like if they are putting some temporary changes and developing any temporary changes, the project will not sustain. The sustainability chances only of there if they are making some changes in the process, in the system, and that should be part of their day-to-day practices. If any new staff comes or goes, this should not be affected. And this leadership has been taken by the HOD, head of the department of OBGY, of course, Dr. Pandey, and the quality improvement team. They have ensured there should not be any temporary solution. All the change need to be applied during the test.
Okay, I think Dr. Kedar, do you have any more questions? Yeah, thank you, Jim. That answered your question. Yeah, so we can go to next question of from Dr. Rupasri. Yes,
just a minute, Gina. Yeah. So because I got disconnected, I missed a little bit, but what I wanted to know was, can we document sustainability on an SPC chart so that it will be better understood by all the people interested in quality improvement?
So you want us to share with you in SPC chart?
Hello.
Yes. Dr. Kedar.
Yeah. So I wanted to know if you have enough data points now, since the study has taken place a few months back. If there are enough data points, can we document it on an SPC chart so that it will be better understood by people as far as sustainability is concerned, or even the changes are concerned?
Sure. In fact,
on the chart, there are only few points.
So here in this, yes, of course, yeah. This is a good point because we are tracking there are not few points actually. They have started working since May 2019, and the data is there for March 2020. So if this is a monthly point of data and more than 12 points. So enough for quality improvement, but this is a case study, and sustainability is a model here. What I'm seeing here, even after COVID also. So it's your suggestion is good. We will capture, rest of this data points also, and we can share.
Yeah, thank you.
Okay.
Thank you.
The next question is very interesting from Dr. Rupasri only. Has there been pre-training knowledge, attitude, practice level determined? And there has been any post-training comparison performed regarding knowledge, attitude, and practices, so that one could identify that the real reason was not deficit of knowledge, attitude, and practice?
See, we have a two component of the training in all the medical college, because the prime focus area of Alive and Thrive is working on the MYCIN, maternal infant young child nutrition program. So two component of training, technical training on MYCIN, quality improvement training was another part. So we have assessed the knowledge on the MYCIN program. And that includes also knowledge, practice, and behavior. But we haven't assessed any quality improvement knowledge program, because we always get very low. Post, of course, what they learn we can understand, but we haven't applied any post training assessment for quality improvement program.
Okay, the next question, I think that answered Dr. Rupasri's question. We can go to the next question from Dr. Rupasri only. Please mention the sample size and statistical tools and techniques used for assessment of data analysis. I think we don't have any statistical analysis and techniques not used in quality improvement. It's a very simple methodology, only numbers.
Yeah, time series chart.
Yeah, time series chart plotted with percentage. Yeah.
What we can demonstrate is on the run charts and SPC charts. That is what we usually demonstrate the statistics. Because here in QI, we have our data over a period of time. So that is then documented on time series chart for a number which is of data point less than say 20. And if it is 20 or more, we can document it on SPC chart. So that is what I was requesting Praveen sir.
Yeah.
That if we now we have the sustainability, we can document, and so that the people will understand it better.
Of course. It's a great.
Sir, could you please explain what is SPC charts in 2 sentences, sir, so that our participants, those who do not know, will have a better understanding?
Should I?
Dr. Kedar? Yeah.
So SPC chart is nothing but a time series chart only, but there are 2 process limits. There is a mean, and there is upper process limit and lower process limit. And your 99% of data, when it is a common cause, it is a routine, it usually will fall, random data will fall within these 2 limits. So if the data falls beyond these limits, then it is considered as a special cause variation. So this is in short, very, very short and gross concept I'm telling you.
Okay.
So you need at least 20 data points.
Monitor the sustainability, right, sir? Okay.
Yeah, and it will tell you whether it's a special cause or a common cause variation. And based on that documentation, you can decide your improvement strategy.
Okay, thank you, sir. Thank you, Dr. Kedar.
Yeah, so Dr. Kedar, just wanted to add, like for in this case, I agree with you. Like if we have a more data case, especially we wanted to understand what was the situation during the COVID time also, because suddenly it was not converted into the COVID hospital, but there is a dip during the COVID. So we can understand what is the scenario. And if we see here, the trend is very simple. Like it's all there is no down till March 2020, where the data has been collected. There is down. Variations can be seen while the COVID was there, right? So they have converted in, even the antenatal care services were stopped. There was no delivery were coming to the hospital. So this could be a good learning. Let me check with them, like what is the status, especially while they were providing the services during the COVID on the antenatal care services. I have noted it. Thank you.
Okay.
Yeah. Yeah, so all these variations will be nicely seen on SPC chart. So you can annotate them and we can have a learning.
Sure.
So what was happening before when you were successful? Now COVID has hit, and so there is a special cause variation. Data has gone down. The improvement has gone down. Deterioration is there. And then something we have done, and whether we have reached to the pre-COVID level or we still not. So then based on that, we can have learnings. And then you can direct our improvement strategy like that.
Okay. So the next question is, what software was utilized to measure the outcome analysis? I think we use only this thing, only percentages and run chart. Software is not utilized in quality improvement. If anybody doing in advanced QI studies, then also I don't think any statistical software for that matter we should use or not. I don't know.
And just to add, we was not able to track outcome in terms of delivery of delivery, the condition of mother and the child, because this is the tertiary level hospital and cater periphery area. So delivery mostly happens in nearby of the villages where the pregnant woman is coming. So process has improved. The care service means services has been improved, but the outcome has not been measured. This was the challenge with this project.
Okay. Outcome was not measured. Okay. So the next question is, what were the limitations during quality improvement project, QIP?
Yeah,
what was the limitations? I think you have mentioned.
Yeah, one that I have just shared now. We were not able to measure the outcome. This was the major limitation with us with this QI project. This, I mean, as a priority, I mean, this was the only I would say I would mention this. Other than this, capacity of lab, because as I mentioned during my presentation, capacity of hemoglobin test and providing the report at the same day was another challenge with this project, because they have ensured like those are coming from the remote area should be able to get the HB test report same day, and so that they can share with the consultant or the specialist. But the local areas, yes, they have to come next day to share, and this was the challenge, and this was the limitation with us with this project since starting.
Okay.
Yeah, sure.
So next question is not clear. Was there train and trainer performed? She can ask that question later. Coming to the next question, what are the documents and level of SOP was utilized for maintaining patient confidentiality and patient privacy? What are the documents and level of standard operating procedures?
So there was no direct patient data was involved here. Individual patient data was involved in this study. So we did not capture any individual patient data.
Okay. Overall process has been the focus, right?
Yes.
So how can we include community? Do you think it's possible and useful? How can we include community?
This is a very good question.
Possible and useful.
Yeah, very good question, because if we talk about specifically antenatal care services, turn up is low sometime, right? Like if the hospital team is asking them to come again to test the hemoglobin next month if the pregnant woman is anemic. So I'm quoting an example. So not necessarily the pregnant women will turn up. If there is a linkage between the hospital to the community level, the information will go back to the community where the ASA Anganwadi worker is working. So they can, or the PRI and other SHGs are working. So the information can go there from the hospital so that they can follow up and send back to at least to the those who comes in emergency category, or those who are severe anemic or anemic can turn up for the next consultation and antenatal care services. So yeah, this is a bit challenging. This project has been done for a tertiary level medical colleges, but this idea is great. This can be tested somewhere else.
Yes. We in quality improvement, we always suggest that involving community will be a great idea. So next question is, what are the pitfalls of this QI project while implementing during check stage in PDSA? That means, PDCA check stage.
So PDS, like patience is very important. Like pitfall is if anything is not working, QI team should not lose the patient because because they need to come up with another idea and again they need to test it. So PDS is there to prevent the failure, right? That's why we test it. So for instance, in this case, hemoglobin testing was not working, and initially even the counseling was not working because one of the HIV counselor was engaged for the nutrition counseling, post-counseling, right? And the last step, she was not able to manage the load of antenatal care services. She was supposed to do the counseling for HIV as well as she was supposed to do the counseling of, antenatal care services. So this didn't work. Again, the team came up with another idea. Let us engage with the GR. GR has been trained and now they were engaged in the counseling. So patience is important. So yeah, so this is the key from my side. Thank you.
Okay. Now, Dr. Kedar has suggested that QI is process management only. He has an objection to that because he says it is not like that. It's not QI process management. It includes outcome also. So we will discuss it later. I think we did not measure outcome in this QI study. Okay, that
so
point is well taken.
this is the limitation.
And what quality indicators?
This is the limitation which I have mentioned, Dr. Kedar, and I explained why this is the limitation to measure the outcome. So the team has decided to work on the process, improving the antenatal care services, right? So if we would be able to measure the outcome, would be great, but this was the limitation of the study.
Okay, thank you, sir. Next question is, can you share the quality indicators were used as performance improvement stage? What were the quality indicators for performance improvement?
So during a time series chart, they have identified the services of antenatal care services like HB checking, BP checking, weight gain, counseling. So these were the service related indicators and they were tracking on a weekly basis whether they are improving or not as part of quality improvement methodology. So they were the key indicators and they, while used during this QI project.
Okay, so the indicators would be percentage of this HB.
Yeah, or antenatal care services indicators.
All antenatal care services.
Yeah.
Okay. Okay. So that were the those were the performance indicators. Okay. Next question is, can you share the scalability in terms of financial aspects for implementation? Financial aspects for implementation?
For a scale up.
For scalability.
Yeah. Yeah, this is very good.
How did you manage the financial? Yeah.
Yeah. For scale up, right, because quality improvement is not like you have trained someone and they have started doing their job. They need a hand-holding support, mentoring support. Initially, at least doing for the first project. Once they are done with the first project, they learn QI and they can do by themselves. So if we talk about the scalability, there are some, financial resources involved if the mentor is coming from another place, like in another hospital or another district. For our case, like what I have shared the scalability pathway where medical college will be helping to the district hospitals and the CSCs. So there are, finances involved just only for the mentoring program, to provide these financial to the medical college so that they can make some mentoring visit initially and the facility could learn quality improvement. So this is the only finances which I see we need to scale the quality improvement project. Of course, the training is another part. Training and mentoring program is the two key component we can say.
Okay. What are your best practices while training the QI?
Best practices while training the QI.
What are your best practices while training the QI
program? So I didn't get, the best practices from the provider side or from the audience side? participants.
Okay.
I don't
From the
understand.
provider
I think
side.
once we unmute Dr. Rupasri, she will
Yes.
clarify this question, right? So next question is, what kind of feedback was collected to say that your QIP was useful? It's only the measurement, or did you take some feedback from the patients, or patients or the healthcare providers who participated in QI project?
No, we haven't taken any data or the patient satisfaction survey of
Okay.
this project. We have taken some exit interview in terms of knowledge while they got the counseling and their understanding, but no patient satisfaction survey has been conducted.
Okay. Please show the feedback data collected by trainers' perspectives, and if it has not happened, then I think we cannot show, right?
It
Okay.
has not happened.
So, Dr. Kamal, could you please unmute Dr. Rupasri so she can ask some questions which were not clear to me? There are 2 or 3 questions. Over to you, Dr. Kamal.
Yes, ma'am. She's already unmute now. So,
Unmuted.
ma'am, you can ask your
Can you-
question.
Can you hear me, please?
Yes.
Yeah, I just wanted to know about the trainer perspective. Was any
Okay.
training given to your counselors or the trainers? This is one question. Second question is, when I said about when patient satisfaction survey is not done, at least your internal people who are there in your team as the HOD or the counselors, their perspective, any feedback is taken in qualitative data or quantitative questionnaires, or how is your effectiveness of your training being performed? If at all it is being, this model is sustainable. Now, the third thing is effectiveness of your training. Just by collecting hemoglobin percentage, height, weight, will the woman's quality of life or quality improvement will be done? Because these are pregnant women, vulnerable people, and 2 lives are involved in this. So how you can improve it for the next cycle of PDCA? So this is my very important point, because in India's nutrition level is determined by the mother. So I want to know for the next cycle, the effectiveness, how you want to improve by adding some more indicators or some more clinical parameters, or is it just that you just keep on telling level of knowledge, awareness, and then it is looking like more of beating around the bush? So internal perspective, stakeholders perspective, at least the feedback is to be taken, right? Has there been any attempt done? And if at all it is there, any data, can you please highlight on this just for interest sake?
So I have mentioned your third questions, half of your third question. Like, we haven't conducted any patient satisfaction survey on this. The 2, yes, of course, are though this team of the medical college, especially the OBGY department and community medicine department was involved there. They were part of this project. So they celebrated the success. We haven't, collected any their satisfaction, because they themselves has done a great job. And this, if you have seen my presentation, this is not only for counseling or collecting some knowledge level. This is a improving of services in a high caseload medical hospital, where 270 antenatal care services monthly coming down, and they are not able to manage. There was no data available for hemoglobin, counseling, weight gain, weight checking, right, and height and weight measurement. There was no data available. So what the team has done, and this is their work, I'm sharing on behalf of Kanpur Medical College. What they have done a great job, like they ensured like every women, those who are coming to their hospital, should get the minimum antenatal care services for that the pregnant woman is meant for. So they have improved the weight and height measurement, and of course, they are categorizing the anemic women also while checking the hemoglobin. Accordingly, they are deciding the next step of the treatment of the pregnant women. So they have ensured more than 90%. So this project was meant for ensuring the services in the medical college hospital, not only for the knowledge or the awareness of the pregnant women. The next step, yes, you asked earlier, and the earlier, participants also asked, what should be the next step? The next step should be the measure the outcome. Starting from receiving the antenatal care services, all the antenatal care services, what is the outcome during the delivery, after the delivery, with the mother? What happened to the mother? Mother was normal? What was the hemoglobin level at the time of delivery? How was the child? Was it underweight or what is normal? So these are the outcome level indicator need to be tracked as a next step. If we will be doing some QI project in district hospital where we can track the pregnant women, and we can link to the community where she lives, and we can link to the community provider also. We can track the outcome of the pregnant woman. So this is high caseload facility where the department and the provider also, they themselves wanted to ensure the service they are providing should be good, quality services. And another question was related to the best practices or the TOT, training of trainers. So training of trainers, no, we haven't organized any training of trainers for medical college people. We have directly trained to the participants, ANT team and quality improvement experts, directly trained to them. We have a module with us, which we have used during the training. The best practices, if I would say during the training, is like if the participants come up with some good ideas of PDSA and they share, they understand the change management, and they also understand these value of use of data and measurement system. So during this training we identify the proactive team members of particular staff. So whenever we have given the training, so those who come up with good ideas of change management, those who understand PDSA, those who understand the value of use of data and measurement system, we noted their name once we went back to their hospital to help them for quality improvement approach. We engaged them as a part of quality improvement team. So we have identified some I would say champions while working in various medical colleges, but we haven't documented any best practices. I hope I have addressed your question. Please go on.
Dr. Rupasri?
Yes, please.
Could you please introduce yourself, madam, please? Dr. Rupasri?
I'm Dr. Rupasri. I'm from Quality and Patient Safety. To mention, I'm a doctor by profession, but entirely depending on quality and patient safety area. I do work for NHS Wales, UK. Now, my question is related to, you mentioned about the trainers being provided with the training program. So may I please know, has there been any reward or recognition or even achievement provided to the trainers being performed? My second question is related to any benchmarking practices has been involved for this QIP. Because we need to know how best is this quality improvement done. So benchmarking levels, has it been determined or predetermined, and then you have been able to implement this? And one more thing I wanted to know is, in the stakeholders' perspective, what exactly would you be thinking in this model to make it more accuracy, or even make it more professional in the future?
Yeah, thank you. So for training of trainers point of view, we have identified some good trainers, and we have, as if we can say this is an incentive for them, like we have listed them as a mentor, right? So the trainer, that only if we talk about the quality improvement approach, the trainer can become the minimum criteria for becoming a trainer or doing a minimum one quality improvement project. So we started with various trainings. They have many medical colleges has done some good quality improvement projects. We have identified these trainers, those who go back and trained again, as a mentor, and they have helped to the other facilities also, as well as some other medical colleges, while scaling up the various this quality improvement training. So, yes, so this we can say this, and making them as a mentor is a incentive for them, and they were very much motivated because they have done a quality improvement project, and this is a magical approach, and they learned a lot. Benchmarking, no ma'am. This is simple tool methodology to improve the processes of care, quality improvement. So we haven't used any benchmarking here. I think benchmarking comes under the quality assurance and quality control scenario. For quality improvement, no, we haven't used any benchmarking. Simple improving the processes of care. The third is
Yeah.
sorry.
Okay. So that answered Dr. Rupasri's question. Hello, Dr. Rupasri. Okay. So I think, am I audible?
Yes.
Yes.
Dr. Rupasri
Thank
is
you
not
so
there?
much, sir, for your replay, and wish you all the very best.
Thank you.
Okay. So thank you so much, Dr. Rupasri, because you have answered so many questions and you provoked our thought process for refining our QI projects. So the as per your questions, the conclusion is one change ideas could be tested with multiple PDSs. Like you asked, the training module to be tested, then another PDSA to be standardized. So one change idea, and there are multiple PDSAs. Then the second message from this QI presentation is QI projects would have process and outcome indicators. Both measurements are very essential. Sorry. And the third, and team should have the clear indicators for measuring processes and outcomes. So thank you so much, Dr. Rupasri and Dr. Ketar, for asking so many questions and make it clear to our participants. Over to you, Dr. Komal. We are exceeding our time limit. Yeah, over to you, Dr. Komal.
Yeah, thank you so much, and that for that wonderful session, and the question and answer session was indeed intriguing. And to conclude, we will request you all to fill in this feedback form so as to improve in a further session. And thank you for attending the session for today.
Thank you very much. Thank you, Gina. Thank you, Christian. Thank you for asking so many questions for
Yes.
to my more understanding. Thanks very much.